So three, two, one. Dr. Rajendra, over to you, sir.
Good evening, everyone. Welcome to this unique event, the first of its kind webinar on lung transplantation, where we've got faculty from across two continents, from India and the US. And these guys who are experts in their specialty will speak to you about lung transplantation. I was just speaking to the team, the panel of experts who are going to talk to you. And we said that lung transplant is in its nascent state in India. There's a few people like Dr. Balakrishnan, Dr. Apar Jindal, who have done this for a few years now and have great expertise. But such expertise is scant throughout the country. And through meetings like this, webinars like this, we hope to make this concept more popular across the country. The Indian Chest Society, and I represent the Indian Chess Society as a governing body member, welcomes you to the meeting. I would like to thank Lupin for their support in doing this meeting. Let me start off by introducing you to our faculty. The first person on the panel I would like to introduce to you is Dr. Harish Seetham Raju. Dr. Seetham Raju is the Medical Director, Advanced Lung Failure and Lung Transplant, Montefiore Medical Center, New York, US. The second person I would introduce is Dr. Deborah Levine. She is Medical Director, Lung Transplant Program and Director of Pulmonary Hypertension Center at University Health System and UT Health San Antonio, Texas, US. The third person would be Dr. Vaidehi Kaza. She's Associate Medical Director of Lung Transplantation, Associate Professor, Department of Internal Medicine, UT Southwestern Medical Center, Texas, USA. The next person on board is Dr. Srinivas Bolanini. He is Assistant Professor, Department of Internal Medicine, Lung Transplant, UT Southwestern Medical Center, Texas, USA. We are fortunate to have Dr. K.R. Balakrishnan, Chairman, Cardiac Sciences, Director, Institute of Heart and Lung Transplant and Mechanical Circulatory Support, MGM Healthcare, Chennai. We've got Dr. Suresh Rao, who is the Co-Director, Institute of Heart and Lung Transplant and Mechanical Circulatory Support, Head of Department, Department of Cardiac Anesthesia, MGM Healthcare, Chennai. Then you have the very brain behind this webinar, a very close friend, Dr. Apar Jindal, who is Clinical Director, Lung Transplant and Pulmonology, MGM Healthcare, Chennai. And then you have yours truly. My name is Dr. Rajadhar, and I work as Director Pulmonology, Fortis Hospital in Kolkata. I'll not bore you with the topics. The speakers will introduce themselves. The coordinator for this entire meeting is Dr. Apar Jindal. And we'll start off with a talk from Dr. Harish Seetham Raju, who will be speaking on management of end-stage lung disease. And then we'll go through the various speakers who will introduce their own topics. We are hoping that we will have enough time for a panel discussion at the end, where we will discuss certain areas which might be more of interest to people who refer patients across for lung transplant, which is the large majority of us pulmonologists throughout the country. And that we'll do for about 45 minutes, where the entire faculty would actually take questions. The only exception we'll have is after the first talk. Dr. Seetham Raju is working at the moment, as you would understand when you see him in his blues. He's also shown me his N95 mask, which is just beside. So we'll ask him a few questions from our side before he leaves. And the remaining people, we are hopeful, will remain back for the panel discussion to take some questions from me and also from all the audience who've joined us. So big thank you to everyone who's joined us. And I hand over to Dr. Harish Seetham Raju. Harish, all yours.
Thank you, Dr. Dhar. Can everyone see my slides?
You need to start sharing, Harish.
I did.
No, we're still seeing your camera, not the slides.
Okay, let's hit share. Do you see that by any chance?
Not yet. Not yet.
So Harish, I'm probably preaching the educated, but if you look at the share screen, that's third, the green arrow at the bottom.
I did that.
Yeah. And then if you click on it and load your talk, it should come up with the list, including your talk on it.
So if it's not showing up as a list, then there'll be options, basic, advanced. Under basic, there would be desktop. You just choose that and then put on your presentation.
Monique, can you help, sir?
Can you see now?
सर नीचे की ओर एक शेयर स्क्रीन करके ऑप्शन होगा.
Are you talking to me?
So no.
There is the option of share screen at below side. At down side, sir.
Harish, your slides are also with the technical team. Do you want them to project the slides from that side?
Yeah, that should be fine.
Monique, you have the slides, just project it from there.
Sir, give me a few minutes. I'm opening.
Yes, sir.
Yeah, Park, can we go with the next speaker and I can join later after the next speaker?
Let's do that.
Maybe we can do that, yes.
Yeah, so let's do that. So we'll wait for Harish at technical glitch. So let's start off with the second talk, which is candidate selection and pre-op preparation. And we'll listen to Dr. Vaidehi Kaza. Dr. Kaza.
Hi, let me see if I can share the screen. Can you see the slides?
Done. Wonderful.
Okay. So thank you for the opportunity to give this talk. I'll try to be short, and thanks for the heads up for trying to address an audience that is not very well familiar. And I will, I think this whole talk could be just about an hour and a half, but I have just condensed it just to make a few pointers in terms of looking at candidate selection. So as you know, indications for lung transplantation have sort of morphed over the years. Initially, when I was in fellowship and Harish was training us, COPD was something that was really what we saw very frequently. And since then, things have changed, and interstitial lung disease is one of the most important or most common indications for lung transplantation. And I believe that may be true even in India, just with the little bit of experience that I've had with APAR. Looking at each individual disease patterns, and for the context of the talk, I've just thought that any referring pulmonologist who's referring patients for lung transplantation for COPD should probably just look at one aspect, which is the Bode index. And the reason that the Bode index is something that's important is it reflects the 4-year survival with the underlying lung condition. So Bode index has B stands for BMI, as you see. O stands for the amount of obstruction with the FEV1, percentage of FEV1, dyspnea, and exercise capacity as measured by a 6-minute walk test. And the Bode score predicts your 4-year survival. And certainly if your Bode score is low, right around 5 to 7, your 4-year survival is pretty right about the range where somebody would be having some sort of survival advantage with lung transplantation. As we go down further, as the Bode score increases, a 4-year survival drops at 18%, which is when we really pursue evaluation and listing for transplantation. And I think as a practicing pulmonologist, when you're thinking of trying to send a patient for lung transplantation, the question that we all ask ourselves is, are we going to help this patient live better, live longer? So I think some of the pointers, some of these risk factors also help us to facilitate right decision-making process. So that's in short about COPD. And there's other aspects that I'm sure Harish is going to talk about managing these patients with end-stage lung disease. Next comes, I think, interstitial lung disease. I have a few more slides on this just to focus on what to look for. So if you're a pulmonologist in the community and you have somebody with a diagnosis of interstitial lung disease, which is usually somebody with as you see in this scheme, in this diagram, somebody with honeycombing, peripheral reticulation, traction bronchiectasis, I think when you see this diagnosis, I think it should be treated with some respect, meaning it has accountability to immediate and long-term survival compared to other diagnostic patterns such as NSIP, hypersensitivity pneumonitis, sarcoid, organizing pneumonia, or other features of interstitial lung disease. And the reason for that is usually patients with IPF tend to have worse survival compared to other lung diseases. And if I were a pulmonologist out in the community, the one thing that I would probably look for is drop in FVC. So if there's a 10% decline in forced vital capacity in about 6 months, then the risk of death in 1 year is pretty high, as you see in this graph, where there's a rapid decline and death in 1 year in patients who actually have forced vital capacity, which drops by more than 10% in 6 months. So for COPD, we look at board score when you're thinking of referrals, and for IPF especially, when we are looking at forced vital capacity with a rapid decline of 10% in 6 months. Now, there is an aspect to this disease process. There are new medications that have come on board. So sometimes we also see a lot of delay in referring to a transplant center. But I think the one key pointer would be a response to therapy or a no response to therapy leading to rapid decline. And this is just a coronal image of a CT with honeycombing in a patient with IPF that we transplanted. When you look at interstitial lung disease in the USA, IPF is about 20% of the entire ILDs, and all the others, connective tissue disease, ILD, are sort of equally distributed. And I'm sure all of you know the physical exam findings and history, where you have the classic Velcro like crackles, clubbing, and the physiological findings of low FVC. And the specific findings of the chest X-ray or CT is what we've just looked at. But looking at the Indian perspective, this was an interesting study that was looking at diagnosis for interstitial lung disease in 27 centers in India. And it looked like 47% usually have a diagnosis of hypersensitivity pneumonitis, while others such as IPF or NSIP are sort of equally distributed. So this was just sort of a simple cohort study that was done, and I'm sure Apar would probably shed light into other aspects of interstitial lung disease in India. But in general, I think when you're thinking of pulmonary fibrosis, the goal is to refer the patients who belong to this blue box, those who have a 6-minute walk test that's declining, forced vital capacity that's declining in 6 months, those that may have secondary pulmonary hypertension, and those that have frequent exacerbations. I also want to caution that this is a group of patients who actually have a high risk of death and usually are also referred later after trying different options for therapy as newer agents have come on recently. And another word, just with connective tissue disease, whether it's rheumatoid arthritis, scleroderma, or with other connective tissue disease, if they have a UIP pattern in the CT, usually they follow the IPF group. Now, next, coming on to pulmonary hypertension, I think that's a very interesting topic, and I think a topic that really needs a lot of work and also access to IV therapies, especially in patients with pulmonary hypertension. And I think most recently the definition is sort of changed or adjusted to a mean pulmonary pressure of greater than 25, wedge less than 15, and a PVR greater than 3 Woods units. When you're looking at pulmonary hypertension, I think when you have inadequate clinical response, and I believe there's only oral therapy and maybe access to inhaled therapy in India, when you believe that there's inadequate clinical response, then certainly I think eligibility for lung transplantation should be considered. There are certain other aspects where I think early, and now that I'm sure Debbie and Harish will talk about it. The goal is to start early with combination therapy and then move quickly to refer to a transplant program, especially when the response is inadequate. The question about lung transplantation or heart lung transplantation is a whole new talk by itself. And I think there are specific criteria that we look for in terms of echo, hemodynamic, or cardiac MRI parameters, which I think the other speakers will go over. So there's another risk score that actually usually helps me to understand patients with pulmonary hypertension, because these are the patients that actually we do not transplant as much as we did earlier on because of these advanced therapies. So if you have somebody with a class WHO class 2, and then have a low 6-minute walk test, high BNP, pericardial effusion, and they have other risk factors. Usually this reveal risk score is something that's online tool that you can get, and the maximum is about 1 to 15, and that reveal risk score usually predicts your 1-year survival. So apart from the features, especially echo parameters, pericardial effusion, clinical worsening despite maximal therapy, and the reveal risk score is usually above 12, your predicted survival is less than 70%. That's when you are thinking about lung transplantation. The one aspect of lung transplantation in patients with pulmonary hypertension is also late referrals because of multiple attempts in trying to optimize treatment strategies. And at that point, usually there's right heart strain, right heart dilation, drop in the ejection fraction on the right side of the heart. So that at that point, I think it's important to discuss whether we can sustain just with a lung or a heart, or whether heart-lung transplantation is needed. The other aspect is cystic fibrosis. Cystic fibrosis is not very prominent in India, but I think something that we can learn from this disease is bronchiectasis, which is either post-tuberculous bronchiectasis or patients with immunoglobulin deficiencies, or with multiple other reasons. The one thing that we can probably take from this slide is patients with bronchiectasis usually need to be considered for transplantation, especially when they have ongoing hypercarbia, when they have pulmonary hypertension, they have recurrent hemoptysis or spontaneous pneumothorax. The main issue in this group is to make sure that they are monitored, surveillance is done for infections, and they are treated appropriately. And I think those infection risks have to be kept in mind, especially when you're thinking of transplant considerations. When you're looking at evaluation, I think it's very important. And the three major aspects is medical, surgical evaluation, and then there's psychological or social evaluation, and then financial evaluation. And the last three slides that I have incorporated some of the questions that Apar had sent me in terms of transplant candidacy, and we'll go over some of these. As part of our UNOS requirement, all of us, Harish, Debbie, and me, are mandated to have this group, this core group, which is important, whether it's physical therapy, financial, nutrition, social work, or psychology, that are part of the core team in our evaluation process. Generally, we do serologies, HLA testing, imaging, and consultations, as you're well, as especially with cardiothoracic surgery, cardiology, and multiple specialties. The main goal in this is to make sure that lung transplantation is not going to hurt the patient, but actually is going to help the patient. So it will also help us to decide whether we are to, just like the reveal risk score and the board score, it will also help us to understand the risk profile, whether this is going to be, or at least to have a gauge of whether this is going to be something which is low risk, intermediate risk, or high risk for lung transplantation. HLA testing is a very complicated topic, but what I would just say is generally HLA is something that all of us are aware of, and we need to look at. These are antigens that are coded by a group of genes in the short arm of chromosome 6. The basic premise of HLA testing and panel reactive antibodies is what we measure in all transplants. Basically, the donor has antigens that the recipient does not have, and that those antigens that are present on the donor, which are absent in the recipient, will then generate some cellular or antibody response that results in damage. So that's the basic premise of HLA testing. And you're trying to test to see if this mismatch is present. And then you continue to monitor, or at least have 3 areas where you focus on, either before transplant, at the time of getting the offer, and after transplant, to make sure that you're containing or managing the cellular or antibody response, and to mitigate the graft dysfunction. But I think there's a lot of progress that's made in India as well in terms of the Luminex assays, or several test strategies that are now available. So I think great progress has been made there. Again, lung transplant program itself is something that has to be a group effort, and I don't think decisions for transplantation should be made by a single person. And obviously, it's a team that decides. And I think I actually, for the preparation, I was thinking about what to talk about, and rather than just putting in slides and what's out there in terms of studies, I was trying to focus on trying to focus to answer the questions that Apar had sent me. One of the questions that I got is, does the distance from the transplant center matter? So for us, Texas is a huge state, and certainly distance from the transplant center is something that we also usually talk about or think about. And mostly, can they relocate? What are the expenses? Are they able to stay for at least 3 months in Dallas, or at least in close proximity to the transplant center? Is what a referring pulmonologist should be thinking about. The other aspect is cost that's involved. So not all procedures, not all interventions can be done. And so can some of the care be coordinated with the referring pulmonologist? And then the other aspect is, what if complications? How do we manage airway stenosis, infections? And if you're thinking of a patient who's very complicated, like bronchiectasis, has multiple multi-drug resistant infections, has pleural disease, would that affect their proximity to the transplant center? Is something that usually we do think about. Now, what can the referring physician do? I think before referring to a patient to a transplant center, certainly getting started with a good pulmonary rehab program, looking at the nutritional aspect, especially the prealbumin and other nutritional markers. What is the antibiogram, and what are the common infections in your community hospital or in your community would be something that would be important. That could mitigate some of the cost also. And also basic workup, like looking at your kidney function, echo, or heart function. And also age is an important aspect that the referring physician needs to be thinking about, especially when you're having a discussion about lung transplantation. The third question that I had is lung transplantation and finances. Certainly the basic rule that everybody is taught is transplant is never the option if it's pushing the patients to poverty. Transplant is only the option when actually they have better quality of life and better longevity. And at least we cannot guarantee anything, but certainly there was one question that was put from which was categorized for me is a middle class family patient who actually wants to come for transplant by selling his assets. Would that be a good option? I would say transplant is never the option if you're pushing this, if that will push this patient into poverty. So I think a good aspect of being aware of the cost of transplantation per se and the cost of maintenance, whether there's other complications that you anticipate, would probably be very important in the decision-making process. And I think that that's about it. So I think we've talked briefly about indications, basic evaluation, some aspects of HLA testing and preparation, and I'll be available to answer any questions. Thank you.
Raja, you need to unmute.
I'm so sorry. Very sorry. Thanks, Apar. So thank you very much, Vaidehi. That was absolutely brilliant. You managed to answer some of my questions, which I was going to ask in the panel. So that's also great, but we'll come back to some of the questions later. We'll move to Harish. Harish, are we good to go? Harish, you need to, same mistake as mine, you need to unmute.
I think so.
Yeah, grand.
Harish, you'll need to log out of the second device, otherwise it will continuously create an echo when you're talking.
Let me. But I'm going to. Are you good now?
You're still on both devices, Harish. So if one is the phone and the other is a laptop or a iPad, I suggest you might want to switch off the phone just for starters. That would probably sort the problem out, Harish.
How about now?
You're still on two devices, Harish, as far as I can see on my screen.
I think I logged out of the other device.
You need to leave meeting from the other device.
Got it. Is that good?
No, you're still on. You're still on both the devices.
I don't think I'm on now. Good.
No,
Harish, what are the two devices? Is it a phone and an iPad? What are the two devices?
One is my desktop and one is my computer.
Okay. Probably better to actually switch one off. that's probably going to be better. I've had this problem before. Even if you're leaving, you're not actually leaving. So that's a problem I have had before with webinars. So if you just switch one off and do it to the, and do it to the other one.
I did switch it off. Can you, do you see me in, you may see me in two devices, but can you hear me properly?
Yes,
I can hear you properly now. There's no echo anymore.
Go
So
ahead.
that's sure. There's no echo anymore.
Screen. Can you all see my screen?
Yes.
We have, great, grand, good to go.
Sorry about the technical glitches. And now I really want to thank Apar and Dr. Dhar and everyone who is hosting us to talk about lung transplant. And I want to take a moment to say that wish you good luck by dealing with the pandemic that is unfolding in India. And we went through a huge challenge 2 months ago, and it has subsided, fortunately. But I think it's a pandemic, and it will go around and may come back as a second wave. So I really wish you good luck. I'm going to quickly add on whatever Kaza has said, and a couple of things that really stood out as what are the options that advanced lung patients can get. In emphysema, which may not be a predominant disease in some parts of the world, surgical options of bullectomy, lung volume reduction surgery have survival advantage as opposed to lung transplant alone. So one needs to aggressively consider patients for who qualify for LVRS. And a recent study from from England, and they think that only we are tapping about 11% of the available cases to subject them to LVRS. So that's a huge gap in what we can offer these emphysema patients who qualify for LVRS. And the newer endobronchial valve therapy to improve functional quality of life is something we would like to consider before considering lung transplant. And the BOAT score is something that Kaza shared. A patient with secondary pulmonary hypertension and emphysema would have a survival advantage, the curve on the right side, and would have a probability of survival is better either with a single and a double lung. How long do you wait? When is the right time to transplant? I feel today patients with secondary cor pulmonale, secondary pulmonary hypertension would be excellent candidates to undergo lung transplant in obstructive lung diseases, especially emphysematous patients. A simple 6-minute walk distance will really delineate a patient who needs a lung transplant today as opposed to wait and see. A simple 6-minute walk distance of less than 150 meters, not 650, less than 150 meters would be a better indicator than an FEEV1 or a heart cath showing pulmonary hypertension. This is a patient referred to me on the left for an ILD exacerbation by an eminent pulmonologist in New York City. And what she ended up having was 2 diseases, emphysema on top with a diastolic dysfunction evidenced by a high LVEDP alone, but the wedge in that patient was only about 14, 15. We ended up managing her diastology and diuresing her with remarkable improvement. Patient came in on high flow FiO2 on the left, and diuresis, patient improved and did not need a lung transplant. The point I'm trying to make is, unfortunately, patients don't read the guidelines or the textbook. They have 2-3 diseases masquerading, and one needs to delineate what is the driving process in a patient with ILD that causes an acute exacerbation. In this case, in a COPD patient who has a concomitant disease, diastolic dysfunction. This is another patient who was recently referred for lung transplant for emphysema. She ended up having vanishing lung with a positive ANA and some of the markers. And we put an endobronchial valve in the right lower lobe and to improve her functional capacity. Actually, she was listed for transplant, but we ended up, because she improved, she was delisted. So other surgical therapies or endoscopic therapies need to be considered aggressively in these patients with advanced lung failure before we resort to lung transplant. Kaza went over that. I just want to delineate a UIP, classic idiopathic pulmonary fibrosis, which is probably the more common disease that we have here in US as opposed to chronic HP. And a lot of patients who have NSIP, open lung biopsy proven NSIP, when they progress rapidly along this curve, when we transplant them, they end up having UIP. I just wanted to state one thing, that a single open lung biopsy proven ILD does not necessarily mean that's what the patient has. They have to fit in the natural history of their disease pattern. Many a times, patients referred for NSIP, fibrotic NSIP, they go down and we get transplant them. The explant lung shows a classic UIP pattern. Again, in an interstitial lung disease, a simple 6-minute walk distance of less than 207 meters is a better predictor of survival. And those are the patients that need to be referred for lung transplantation. Simple 6-minute walk test can be executed in a primary care setup. And this has a better predictor of survival than forced vital capacity, existence of pulmonary hypertension, and other medical comorbidities, including the BMI. So one needs to keep that in mind. And we end up giving a lot of immune suppression in this collagen vascular ILDs, and because we like steroids. As lung doctors, we like prednisone, mycophenolate, azathioprine, Cytoxan. And there are definitely some patients who benefit from that. But the most important decision one needs to make is it imperative that when to start and when to just observe without any intervention. And that is very important in the treatment of ILDs. I'm going to state one thing on the coexistence of mean pulmonary hypertension in collagen vascular ILD, which is often under-recognized as the driving force for the ILD. So this is an open lung biopsy proven patients and their survival with collagen vascular ILD. At 0.0, they all had right heart caths showing mean pulmonary pressures more than 20 or less than 20. And that's their survival curve. So even if the mean pulmonary pressures on a right heart cath, if it's more than 20, their survival is dramatically worse than the survival without coexisting pulmonary hypertension. That's often a misconfounding factor in the management of collagen vascular ILD. And two diseases can coexist. This is a patient referred for lung transplant, but their PFTs are near normal. Forced vital capacity is 90%. Combined pulmonary fibrosis and emphysema. Smokers have a high risk for developing fibrosis. They have emphysema in upper lobes, classic UIP pattern lower lobes. Their PFTs are normal. They look great, but they may go down rapidly at the onset of any infection or an exacerbation. Again, this is a patient who was referred for she's one of my patients who had open lung biopsy and she had NSIP. She was on mycophenolate and a low dose prednisone. She ended up having an acute exacerbation at an outside hospital. And she got a gram of steroids for 4 days. She didn't get better. She was transferred to our service. I ended up doing a bronchoscopy BAL when a patient is intubated on 100% and FiO2 and PEEP of 15. She had two diseases, pulmonary alveolar proteinosis with coexisting NSIP. So what this patient ended up was getting a whole lung lavage and GMCSF with remarkable improvement in symptoms, and she continued to do well. And the follow-up CAT scan shows remarkable improvement in her disease. The point I'm trying to make in these few cases is when the patients do not fit in the natural history of a disease, one needs to look for confounding factors, and they could be multiple, and one needs to be careful about that. Kaza touched on the PAH part, and today we start upfront dual anti or triple therapy, and Debbie is an expert in this, and I'll leave that. A patient who is not responding to appropriate pulmonary vasodilator therapy, this is a patient referred to me for PAH, and she was not responding. She initially responded for vasodilator therapy. Now she stopped responding. We ended up transplanting her. The reason I want to show this is this fine nodular pattern suggestive of pulmonary veno-occlusive disease. There is a good percentage of patients with pulmonary hypertension who do not respond or who initially respond and fail to respond later. They may actually have PVOD. If we ended up transplanting her and look at her lung, explant lung, she has classic PVOD. ECMO bridge to transplant is real, and these are the patients who are young, who have one single organ failure, and who are otherwise intact and have a rapid progression in their underlying lung disease can be bridged through ECMO to lung transplant. And this is one of our patients ambulating on ECMO, and this is a real entity that one needs to aggressively consider. I'm sure Dr. Bala does a lot of ECMO support at Ramchandra Institute. And bridging to transplant is vital when they're ambulating. If they're not ambulating, then these patients do not do well. These are our bridge to the recovery and bridge to transplant. This is probably my second last slide. When do you consider referring a patient to transplant? Today, we have the advantage of looking at the experience of our mentors and look beyond. And we have the fortitude of knowing the natural history of a disease, UIP, pulmonary hypertension not responding to therapy, ILD, chronic HP. We have the luxury of knowing their natural history. Based on their pulmonary function testing, based on their coexistent pulmonary hypertension or not, today we have the chance to predict their outcomes in the next 2 years. If the survival in the next 2 years is less than 50%, then those will be the candidates that need to be referred, evaluated, listed, and transplanted. They may not look really bad, but that's the timing of referral and transplantation. And lungs are allocated by lung allocations code today. And these are a couple of one of our patients. And the reason I wanted to emphasize on the steroid use is this. This is a patient with diagnosed NSIP getting high dose steroids. We bridged him to transplant, explant lung showed UIP. And this patient on the left was on 2 liters O2 with the post-lung transplant day 8. And the right lung has a little infiltrate, but the patient was looking great. Overnight, the patient decompensates, gets intubated, And the infiltrate on the right did not look that bad if you look at it, but the patient is acutely hypoxic and deteriorating. So this patient had pulmonary vascular stenosis right there, and ended up getting a pulmonary artery stent with remarkable improvement. I believe that pre-transplant usage of high-dose steroids has a dramatic effect on the healing of these vascular anastomosis. So minimizing steroids before transplant is vital. And ultimately, organ donation is something we all need to strive for, and that's what saves lives. And that's the end of my talk. And I think I have 2 minutes.
Thanks, Harish. Great talk. So I think two of my learning points from your talk, two take homes for me was the couple of cases of the three cases where you mentioned about looking for other etiologies, interventions, which actually made the requirement of transplant go away. You know, I was fascinated by your lung volume reduction therapy case. I was fascinated with your pulmonary alveolar proteinosis case and the fact that they got better when they came into you with a transplant referral. And I think the message about reducing immunosuppression, reducing steroids, is especially vital. And I'll probably discuss this more during the panel, especially in the COVID era. Thinking about immunosuppression, thinking about the dose of steroids is something which is, again, vitally important today. Harish, are you going to be with us for maybe another half an hour, 45 minutes while we finish the talks? I'll ensure we'll ask your questions at the very beginning if you promise to stay for 40 minutes. Sorry. Sure. Is that all right?
Yes, no problem.
Grant. So we'll move over to Deborah. So Dr. Deborah Levine, tackling rejections. Deborah, all yours. We'll have to, yeah, Grant.
Oh, hello. I'm just trying to get my slideshow. And still not slideshow. Okay, that's good. Thank you. And of course, I really want to thank Par for inviting me and the whole organizing committee. This is an incredible panel. The people that are on this are, this is a great session. Hope everybody is staying safe. I am actually going to talk about what happens after transplant, and rejection in lung transplant is so imperative. It's the lungs are so much more fragile than other organs, and our rejection rates are much higher, and our survival rates are a lot lower than even liver, kidney, and heart. Because patients are going out to see their pulmonologist or moving home or moving far from the transplant center after transplant, I think it's important that we talk about rejection, what types of rejection there are, and how to possibly treat it. I think oftentimes patients are sick while they're at home. And even if you have a conversation with your transplant center, you can be talking about what's going on with the patient with them, even if the patient has to not come back to the center. So I think identifying and being able to at least think about diagnosing rejection, even if the patient is not near their center, is important. And that's why I thought it would be a good talk to have for people even not doing lung transplant. You're still going to always see them, especially as lung transplant grows in India and the centers become more active. So as I said, we've been doing more lung transplants in the world over the last several years, but one thing that has still not become successful is really having a better survival. And this is a slide from the International Society of Heart Lung Transplant that shows, you know, looking at different eras of transplant. we still see that from early on and now, we still don't have a much improved success in our survival time. In fact, the median survival on the last IHSLT showed only a 6.5-year, 50% survival. And most of the time when you talk about survival in lung transplant, you look at the 1 year and then after 1 year outcomes. And you can see from this second slide from the IHSLT guidelines that within the first year, infection is usually the main cause for death in these patients. But after 1 year and beyond, really for the patients the rest of their life, chronic lung allograft dysfunction, or CLAD, or another name for chronic rejection, is the major cause of mortality. Chronic lung allograft dysfunction, or CLAD, is really made up of multiple risk factors. And a lot of these risk factors include actually, I don't know, I think it's moving on its own, acute kinds of rejection. So that can be acute cellular rejection, acute antibody-mediated rejection, and lymphocytic bronchiolitis, which is another type of rejection. There's other risk factors for CLAD that are non-immune, including reflux in all types of infections, including viruses, fungal and bacterial infections. And then, as Dr. Kaza talked about, donor-specific antibodies, or antibodies that the recipient makes to the donor. All are risk factors for CLAD. We're going to be talking about the risk factors for CLAD that are really focused towards the rejection. And again, there's two types of acute rejection, acute cellular rejection and acute antibody-mediated rejection. Acute cellular rejection is really mediated by T cells that recognize antigens and other HLA antigens and causes a cellular rejection. Most known and probably the most well-treated and most well published is acute cellular rejection, but we also know that antibodies can also cause rejection. We also know that the binding of these antibodies can lead to lung dysfunction and decreased survival, as well as lead to CLAD. We also know that oftentimes it's a mixture of antibody and cellular rejection. So we're going to go through this based on each one. So acute cellular rejection, we'll talk a little bit about the background. You can see that in the literature, you can see papers that say 26% of patients have acute cellular rejection in the first 2 years and up to 90%. And that is because there is such an inter-observer variability between biopsies, between evaluations, in why or how people really describe their patients with acute cellular rejection. In fact, in a registry, in a large registry, they looked at this, and different centers had a much different incidence based on how they were defining it and how they were reading the biopsies. So I think it's very unclear, and I think most people think that ACR, or acute cellular rejection, is much more underreported than really known. Again, both the severity of the rejection and the frequency of rejection can be highly related with CLAD. And remember, this type of rejection can occur frequently. It doesn't just happen once. You can have recurrence. Acute cellular rejection also, if a patient comes to you and they're having symptoms, can that really predict if they're having cellular rejection? Well, when symptoms are there, and oftentimes there's no symptoms, but when they are there, dyspnea can only be really adjudicated 63% of the time, and that's with a higher grade of rejection. A cough, the sensitivity is about the same. So that means that oftentimes there may be no symptoms and there may be very nonspecific findings. What about radiographic findings? Well, in a chest x-ray or a CT, when it is abnormal, and oftentimes it's not abnormal, you can have ground glass opacities, some types septal thickening in the CT scan, and maybe some areas of atelectasis, oftentimes a lymphocytic pleural effusion. But again, nonspecific findings may be there, and it can raise a suspicion to look for more investigation, but oftentimes you may not have any of these symptoms. Because of that, patients are often looked at with surveillance spirometry, and these are spirometry routinely performed either in the clinic or with home spirometers. Basically, in the definition, a decreased FEV1 of greater than 10% from baseline might want you to start looking into, does this patient have rejection? However, just like for the clinical and the radiographic findings, stable FEV1 does not exclude ACR. In fact, when patients were looked at on surveillance bronchoscopy, many people were done, these were performed on patients who had stable PFTs, but they were still found to have rejection. The gold standard to diagnose acute cellular rejection is biopsy-proven diagnoses. And many centers, 60 to 70% of the centers, at least in the US, do surveillance bronchoscopies, which is multiple bronchoscopies at different serial bronchoscopies during the first and second years to see if there's any silent rejection or silent infection. Many people perform just for-cause biopsies when there is an FEV1 drop or symptoms. So some centers look predictably and some look if there is a cause. The reliability, as we discussed, of these results is limited by inter-reader variability in sampling error. It is a very heterogeneous diagnosis, and usually 6 to 7 biopsies are done to get a good reading. The International Society of Heart-Lung Transplant defined ACR based on the biopsies, and they looked at grades, meaning the severity based on the changes in the biopsies. Acute cellular rejection is really signified by a perimononuclear infiltrate around the vessels. And as that kind of infiltration of the inflammatory cells goes out into the periphery, or into the periphery of the lung, that becomes more severe. Patients are also looked at peribronchial mononuclear cell infiltrates around the airway as well, and that could include a lymphocytic bronchiolitis. So acute cellular rejection includes both vessel disease around the vessel as well as the bronchioles. If a patient is diagnosed with acute cellular rejection, we usually have some kind of standard therapy, and most of that is usually a few days of very high dose steroids, usually 500 to a gram of prednisone, followed by an oral taper. You can consider, or the center would consider, switching maintenance therapy. You would prophylax for infection, and usually for a regular ACR, you will see some good response in terms of increased PFTs and improved symptoms. Many of these ACRs are refractory, excuse me, and some of them require a repeat course of steroids and maybe higher therapies or more aggressive therapies to treat them. Antibody-mediated rejection is rejection that is caused, as Dr. Kaza had talked about, by antibodies from the donor that the recipient is having, or donors specific antibodies. Early studies looking at antibodies and rejection show us that really they looked at antibodies in general. At that point, they weren't looking at donor-specific antibodies. It was more just antibodies. And they found that antibodies do precede rejection, and they also precede a worse survival. Newer studies in the late 2000s show that both donor-specific antibodies and the rejection they cause are associated with increased clad and decreased clad-free survival and decreased survival. Back in 2016, antibody-mediated rejection of the lung, a consensus report by the IHSLT was developed looking at these 5 characteristics: circulating antibody in the serum, allograft dysfunction, so change in PFTs or symptoms, histological changes, positive C4D or complement staining within the graft, or exclusion of other causes for the allograft dysfunction. What they did was they talked about patients having either possible, probable, or definite antibody-mediated rejection based on the number of those diagnostic criteria in that patient. So if a patient had both a donor-specific antibody, changes in the PFTs, and changes in the biopsy, that patient may have a probable antibody-mediated rejection. If they have all of the causes or all of the characteristics, that would be definite. The interesting thing is the patient can have clinical, meaning with symptoms or with changes in function, or subclinical, meaning patients don't have any clinical signs at all, making it difficult to diagnose. These are some of the histologic features you may see in AMR: and arteritis, sometimes acute fibrinous organizing pneumonia, acute lung injury or DAD, and capillary inflammation where the C4D is positive. And again, that's a complement stain, saying that there's complement binding to the lung. So all of these characteristics are important to look at, but there's definitely limitations of our current knowledge. There's a lot of issues with our current tools that we just talked about that may limit both the identification and risk assessment of antibody-mediated rejection. Each of these has different issues: decreased sensitivity and specificity of C4D, inter-reader unreliability and pathologic characteristics, pulmonary function isn't always down, and antibodies, you may not always find them, either because they may not be HLA or they may not be detected by that particular lab's assay. So we have a lot of work to do in really figuring out what are the best tools to figuring out antibody-mediated rejection. So if we think the diagnostics is difficult and very heterogeneous around the lung transplant world, the current therapies are even more varied. These are multiple therapies that are looked at in these patients, and they're either looking at depleting the antibodies or by decreasing the production by making B cell depletion. So there's many therapies. They're not all benign and very difficult to get in many cases. They're very expensive, and they're sometimes very difficult to get. What about chronic lung allograft dysfunction, or CLAD? This is what we talked about as the main etiology of decreased survival in our patients. Sorry about that. Again, we talked about the different types of risk factors that we've already talked about: acute rejection, whether it be antibody or cellular, being some of the main causes. When you talk about diagnosing chronic lung allograft dysfunction, this is a patient who has substantial and persistent decline in the FEV1 from baseline. Patient usually has a greater than 20% decrease in his best FEV1, which is persistent over months. The IHSLT in 2019 looked at how we stage these patients, and again, it's by FEV1. These patients are difficult because patients decline at a different rate individually, and so patients can live for a long time with CLAD. but we also know that clad-free survival decreases as the severity goes up. There's probably multiple phenotypes of clad. However, the two major phenotypes that have been best elucidated by the IHSLT are bronchiolitis obliterans syndrome, or BOS, which is the major type, and then restrictive allograft syndrome, which is probably up to 20 to 25% of patients who have clad. And a great paper, if you got two great papers to look at that came out last year, were in the Journal of Heart Lung Transplant to evaluate our, this one by Dr. Vierlinden and by Dr. Glanville, talking about BOS and RAS. Again, there are probably multiple types of different phenotypes, one being a mix between BOS and RAS, and maybe some being undefined. For BOS, or the bronchiolitis obliterans syndrome, it's an obstructive phenotype with decreased FEV1 FVC ratio, and really not a lot of changes in terms of increased infiltrates on the CAT scan. It's more of a air trapping type of CT finding. RAS, restrictive allograft syndrome, you may see a patient that comes in with some fibrotic changes or even some infiltrate throughout, with actually a decrease in their total lung capacity. So more of a restrictive look on their PFTs. These patients have a likely worse survival than those patients with BOS. Then there's the mixed and undefined phenotypes. It's probably a combination of both. So in terms of, oh yes.
I'm sorry, can we finish up in the next 1 minute or so? Thanks.
Yes, we can. Sorry about that. So serial spirometry is how we find these patients, and we really have a very difficult time with treatment based on not very many of these work, but we can talk about that more in the questions. And I guess the biggest summary is that really we want to find anything we can so that we can prevent CLAD. The severity and the frequency of acute rejection are definite problems, and there's limited treatments for CLAD, but are good treatments for acute cellular rejection. Thank you, and I'll take questions at the end.
Thanks, Deborah. That's brilliant. That's a very difficult topic, and you've made it very lucid for all of us. Grand. We'll move on. We want to finish in the next half an hour or so. So it gives me great pleasure to invite Dr. K.R. Balakrishnan. I don't think Dr. Balakrishnan needs much of an introduction in this country, and he's going to speak about challenges in setting up a lung transplant unit in India. And it's a topic of great relevance, importance, and interest to me and the rest of the audience. Bala, all yours.
Thank you. Am I seen?
Yes, we can see your slides. You can just
All right.
go and show. You can play that.
Okay, thank you for this wonderful opportunity. I have to confess that I came to know that I'm going to make a presentation 15 minutes ago. So I quickly put together, I was given to understand initially that this is going to be a panel discussion. Nevertheless, this is an important topic from the context of this country. It's not even a decade since organ donation took off in a significant manner in this country, even though the Transplantation of the Human Organs Act was passed by an act of parliament in 1994. And the first cadaver heart transplant was done way back 2 decades ago of the All India Institute of Medical Sciences. It was not till the year 2010 that there was a systematic and organized distribution of organs. And to a large extent, this was started in the state where I work. I'm in Chennai, in the southern city here that you can see. And the state of Tamil Nadu took the lead. And over the last 8 years, as you can see from this slide, there's been a considerable progress in organ donation. And all those brown circles you see are the states in this country where some kind of organ donation exists. Curiously, the majority of organ donations, I would say over 90%, happen south of the line that you see drawn across this country from Mumbai on the west coast to Visakhapatnam on the east coast. And the reasons for that would perhaps belong in another domain. It's more of a socio-political issue than medical. There's been a steady increase in the availability of donor organs. In the 2018, I think close to 715 organ donations took place. Around 222 hearts were transplanted and around 75 lungs. And in our own state, this has been the increase in the transplant activity. And we do close to 80 transplants a year in our own unit, around 65 hearts and around 15 to 20 lungs. Lung transplantation started in India, I think, fairly recently, only in the year 2012. Again, interestingly, over 95% of all lung transplants in this country happen in 4 major centers in the city of Chennai, where I live. So coming to the topic of challenges in lung transplant, the first challenge was in reaching the organs to the hospitals. And that's actually a major challenge. Sitting in the United States, you might not appreciate the kind of difficulties we had to overcome to establish fairly basic things in this country. If you look at inner city traffic, this is actually a better looking traffic than you'd see in other cities. This is the Connaught Place from Delhi. In most major metros, it's even worse at this point in time because of the COVID crisis. Traffic is not so bad. So imagine when we started, given the ischemic times that we were comfortable with for the heart and heart lungs and perhaps lungs, the first challenge was to establish how on earth are we going to reach organs from wherever the organ donation took place to the hospital where the transplant happened. So in the year 2008, in our city, we approached the police commissioner. Indians are very used to having police escort for VIPs, for the chief ministers and other ministers. So we asked him whether he could provide some kind of an escort for the organs. And we had a very helpful police commissioner at that time. And this practice started in the city of Chennai 12 years ago, where a donor organ was ferried across the city with a police escort. So all the traffic was stopped and all the traffic signals were made to become green. And this was called the Green Corridor. And this is an example. The video is being shot by an ambulance carrying the organ. That's the ambulance. Interestingly, I use this because this was in the city of Vijayawada. Those of you who are familiar with this country will know that in the month of May, Vijayawada is very, very hot. The ambient temperature was 49 degrees when this video was shot. And yet people were standing, I think it was the first long distance procurement in that city. And there were people lining up the sidewalks, throwing flowers at a dead man's organ. So one of the reasons why we've had such a pronounced increase in the organ donation rate has been the public acceptance of a good deed. And this eventually, the press noticed the fact that the Green Corridor concept was used for transporting organs. And this received wide coverage in the year 2013 in the national press, including in the headline news in the Times of India, and it caught international attention. And this was a young girl who got the organ for that particular organ, a young pretty girl from Bombay. And she now actually is a transplant coordinator. But the reason I include this story in a talk on lung transplant is that this resulted in a very substantial spurt in organ donation in this country. As you can see, from the year 2013, when this news was reported, there was almost 100% to 200% increase in organ donation. So organ donation cuts both ways. Positive stories have a huge positive impact. Of course, it could go the other way as well. The other challenge was long distance procurement. With more awareness, we started getting organs in other cities. A lot of these organs were in small towns, which don't necessarily have an airport, and the roads often may or may not be very good. So ferrying donor organs across a geographically vast country is a huge challenge. Again, the availability of a private jet cannot be ensured at short notice, especially in the middle of the night. This is particularly true because donor families, for cultural reasons, often want the body of the donor back before sunrise. So the window of opportunity from the donor call to harvesting can be very short. The costs of these air ambulances are often highly unregulated. The cost has to be borne by the patient and is often prohibitively high. I think Dr. Vaidehi spoke about pushing patients into poverty. I mean, it's a reality in this country, not necessarily for a transplant for most illnesses, which are major. So it's a very difficult situation when you're waiting for an organ on ECMO or short-term MCAS for a heart. And if for some unfortunate reason the organ turns out to be unusable, I mean, you can have all the details you want on the telephone by talking to the intensivist looking after the donor. And by the time you arrive, the patient's heart or lungs could become unusable, or he could have had a cardiac arrest. The cost of the jet has to be still paid for, and by whom? So these were huge challenges. So sometimes perfectly usable donor organs are not used because of logistic issues. So we had to overcome this. As I said, so we started looking at using commercial airlines as a viable and safe and effect. So we put in place a mechanism where we classified airports into tier 1, tier 2, and tier 3 cities. We took the telephone numbers of the air traffic controllers. I mean, you'll be surprised, this is really not the job of a surgeon to do, but somebody had to do it. So we really worked on the infrastructure part of it in a very major way. And this is an example of a box carrying a donor heart or lungs, ferrying across a busy airport terminal. It has to go through the security clearance and x-rays. Again, as an anecdotal reference, in the beginning of the program, this box size was not standardized, so sometimes it would get stuck at the x-ray. And the box is kept in a passenger seat next to the people who carry it. These are a surgeon and the transplant coordinator. And this is a boy who had a heart and lung transplant with their organ that you see in the donor green corridor. So the effort is worthwhile. So the cost incurred, we did a formal study, is 10 times. If you use the commercial airlines, the cost is between $120 to $3,400 compared to up to $27,000 for an air ambulance. And this was published in the Journal of Heart and Transplant a couple of years ago. So we now use air ambulances or regular ambulances for transporting patients in ECMO. So this is the patient. The sound here is transported by an ambulance. We've gone as far as Hyderabad or Belgaum, a good 18-hour ride on an ambulance carrying patients in ECMO for either a heart or a lung transplant. This is a patient who was transferred for a lung transplant on ECMO. And this is a patient who could afford an air ambulance, so it's easier to shift them. Even here, there are huge issues because these are not regularly built to be air ambulances. The doors are very narrow. The plug points often are single, so we had other challenges to overcome. And sometimes we transport patients in trains. This is a patient with severe biventricular dysfunction and pulmonary hypertension referred for a heart and lung transplant. As you can see, he's being transported by train. The next thing is, I think Dr. Sitaram spoke about the use of ECMO. For a country with fairly early experience in lung transplant, a disproportionately high number of patients are on ECMO because by the time they are referred to us, they are very sick. And so this patient was on ECMO for venous ECMO for 45 days. He was on a ventilator for 60 days and underwent a bilateral lung transplant. And 4 years later, he's not recognizable. We also, this is a patient awaiting a heart and lung transplant, complex congenital heart disease with pulmonary edema. He crashed. So we mobilized patients even on a veno-arterial ECMO through the groin. So this boy is walking around with a veno-arterial ECMO, helped by support staff. Again, late referrals. This 73-year-old lady is 1 year post-lung transplant. She's oxygen dependent, total respiratory cripple, couldn't get out of bed. So after a lung transplant, she's at least mobilized enough to walk inside the house. One of the questions which is asked of in the thing was severe right ventricular dysfunction. We take it on a case-by-case basis by looking at the MRI and echocardiogram. The young girl, CVP of 30, PAPI of 0.9. Waiting times for a heart lung are much longer. She was sick. She couldn't afford a novo lung. We went ahead and did a bilateral lung transplant. We have a very low threshold for supporting these hearts with dysfunction on ECMO post-op for a couple of days, and she did very well. In some patients, we put them on preoperative ECMO. This patient had cardiac arrest, was put on ECMO, and then underwent a successful bilateral lung transplant. I'll skip the operative slides. Challenges in donor selection. Sepsis is a huge issue, which I think we'll discuss in the panel discussion. We don't have a uniform policy of donor management across different states and different intensive cares. So perfectly usable lungs can get damaged by improper fluid management. This is something we've been trying our best to implement at a national level. And of course, organ transport I've already alluded to. In terms of complications, like any other unit we've had our share, bronchial dehiscence happens once in a while. This is a patient with a left bronchial dehiscence who underwent a stent and did well. This patient had a tracheal dehiscence and had a bifurcation stent in the trachea, which we removed after 5 months. This patient has done well. Cost is a huge, huge challenge. Public funding for transplants is there only in a couple of states, Tamil Nadu and Andhra Pradesh. I think Telangana fund. Our state funds reasonably well, but none of the other states has any funding. So that's a huge challenge. How we shall overcome it, I do not know. The quality of life is excellent. This young girl had a heart-lung transplant for Eisenmenger with severe biventricular failure. She was the first transplant from the state of Arunachal Pradesh, and I had an opportunity to visit that beautiful state, and they get transformed. In 6 months' time, we can't recognize these patients. So a lung transplant is a reality in this country, and hopefully in the coming years, with the help of experts like those in this panel, we are able to fine-tune our own program so that we make substantial progress. With careful case selection, excellent functional outcomes are possible. And of course, donor-derived lung sepsis continues to be a big challenge. And I think we need national policies on antibiotic usages, including restricting or banning colistin usage in chickens. Thank you very much.
Thanks a lot, Bala. Absolutely fascinating talk. I mean, gobsmacked. Wonderful. Really enjoyed that talk. For the last talk, last but not the least, I'll invite my dear friend, Dr. Apar Jindal. And Apar is going to talk on a topic which I am very interested in. It's a topic that I had suggested to Apar. So Apar, I'll leave it to you, last 15 minutes, and then we'll have the panel. All yours.
Thank you, Raja. So let me get my slides on. And I hope the slides are visible. Okay, so coming to the last stop, and I think all the previous speakers have already set the stage for me. What I am trying to do is now create a link between the transplant team and the referring physician. So I'm going to touch slightly a few slides about the airway complications that we commonly see post-lung transplant. And then I'm going to talk more about the long-term complication and what the referring physician needs to keep a lookout, needs to keep a watch out for once the patient goes back to him. So these are routine follow-ups that the referring physician can do and then get in touch with the transplant team in case things go south. So basically, we are going to review airway complications, long-term follow-up, and the metabolic complications. And I'm going to touch upon a few of them like diabetes, hypertension, osteoporosis, and malignancies. I confess that I won't be able to go into details about all of them, but I'll just spend 2 or 3 slides on each to touch briefly upon them. So basically, when we look upon complications post-lung transplant, we can see that the incidence of these complications vary over a period of time. As we can see early on during the post-transplant period, infections and graft failure is our major concern. But as we advance in time and as we cross the threshold of 3 years, 5 years, and 10 years, graft failure and then other complications become more important as compared to infections. Although you can see the cardiovascular, I would rather put it as metabolic complications, play a subtle role throughout the period. Now, starting with the airway complications, there are different types of airway complications that we see. Sloughing of the airways is seen in mostly 50% of the cases, and this is mainly a reaction of the airway mucosa to the ischemic changes. And other than that, the more important ones that we see are anastomotic dehiscence, like the case that Dr. Bala showed, and I'd be showing some more slides on that. Exophytic granulations, bronchial stenosis. Now, this can be at the anastomosis, or this can be more distal to it. Vanishing airway syndrome, where we end up losing some lobes. Tracheobronchomalacia, bronchial fistulas, and anastomotic infections are the other commonly seen airway complications post-lung transplantation. The main process by which this comes can be divided into recipient issues, donor issues, and the transplant process per se. But one important thing that we all need to remember is the one implicated thing is that ischemia during the transplant period in the peri-transplant and the post-transplant area is probably projected to be the most important factor which leads to the airway complications. We need to remember that post-transplant, bronchial arteries are not anastomosed. So the new lung receives its blood supply only through the low pressure flow from the pulmonary arteries. So if this is absent for a long period of time, or if this is not restored well, then this leads to airway complications as we see. Therefore, again, and evidence to that is also that more common airway complications we see in the right anastomosis and in the right bronchus intermedius as compared to anywhere else. So ISHLT has come out with a paper classifying these complications into ischemia, necrosis, infections like aspergillus are very common in the peri-anastomotic area, dehiscences, stenosis, and malacia. So these 6 are the main categories, and then they can be subclassified into depending upon the severity and depending upon the location where we see these complications. I'm not going to go into the details of that, but then there was a great paper in CHEST in 2017, which clearly laid out guidelines as to how these need to be treated. A very important point over here is, and in a recent webinar, I heard a lot of the international faculty also speaking, is whenever in doubt, you bronch the patient. So it is very important for us to choose whether the patient is symptomatic or not, and then bronch the patient to see what complication we are dealing with, and then plan accordingly. So in case we have a stenosis, we need to see where the stenosis is. Is it in the big airway? Is it in an airway which is more than 12 mm, or is it in one of the distal airways which may be around 8 mm or less? Depending upon that, we start with bronchial dilatations. We can sometimes use electrosurgical instruments to create more space and achieve dilatation. If dilatation by ballooning is not possible, then we end up putting stents. Similarly, in bronchomalacia or tracheobronchomalacia, if there is more than 50% narrowing of the airway, then we should have a low threshold for stenting these airways. Otherwise, the patients are more prone to develop distal airway complications, and also they are at risk of developing lung atelectasis, which will lead to further problems in these patients. Now, choice of stent will depend upon multiple things over here. It will depend upon the site where you need to put a stent. It will depend upon the expertise, and it will obviously also depend upon the availability of the stent at the center. So I'm just going to show a couple of videos over here. So here you can see the dehiscence which is present at the anastomosis. So a stent was deployed for this, and you can see in the video further as we go that the dehiscence is totally covered with that stent, and the patient improved post-stenting. Similarly, another case I'm going to show you over here is this is a tracheal anastomotic dehiscence for which a Y-covered stent was used for managing the dehiscence. Moving on to distal airway stenosis. This is a video which shows airway stenosis, which is, if you follow the bronchoscopy, you can see that we are not able to enter into the right upper lobe, and the right bronchus intermedius has a tight stenosis over there. This was managed by using CRE balloon dilatations. You can see that the upper lobe is now well dilated, and I can pass a 6 mm therapeutic scope into the upper lobe. So for the right bronchus intermedius, we used electrosurgical instruments. A cautery was used to make radial incisions, and then ballooning was done to maintain adequate airway space. Moving on to the topic of bronchomalacia, you can see in this video that there is a severe narrowing over here. It is much more than 50% narrowing, which was managed by using a stent. Here, usually we use either silicone stents or we use covered metallic stents, but because in this particular bronchus, the landing zone was much less, I used an uncovered stent over here to protect the right upper lobe so that that remains open and air enters into the right upper lobes. So changing tracks over here and quickly going on from airway complications to post-lung transplant long-term morbidities, here the role of the pulmonologist changes slightly. Here, it becomes almost like pulmonary medicine has gone on steroids, and we become more like internal medicine doctors treating multiple comorbidities in these patients and not just issues relating to the lungs. So I'll touch about hypertension, diabetes, certain malignancies, one by one, and osteoporosis. I picked up the few for which robust data is there and which really need to be looked into. To start with hypertension, the incidence according to the ISLT registry is about 52% in the first year and about 83% in the 5 years. And the various reasons which have been put forth why people develop hypertension post-lung transplant is either due to previous disease. Most of these patients are at advanced ages and they develop hypertension due to various other reasons. Or it could be a new onset hypertension because of the use of calcineurin inhibitors. The proposed mechanisms here are increased endothelin 1 levels, decreased endothelin-derived relaxing factors like nitric oxide, and decreased renal blood flow. The other reason why they can develop hypertension is chronic steroid therapy, both pre-transplant and then the continued steroid therapy as part of the maintenance immune suppression post-transplant. When we looked at the choice of immune suppression over here, the CNI, does it make a difference? We didn't find a significant difference between the use of cyclosporin and tacrolimus as compared to the diabetes patients, which we'll come back to later. So moving on to the management, the basic principles remain the same. There are standard management guidelines which are followed for hypertension while keeping into account the concerns like hyperkalemia, the incidence of chronic kidney disease, and interactions with the other CNIs or calcineurin inhibitors. We have to look at the coexistent cardiac morbidities, especially look for atrial fibrillation and also look for presence of diabetes in this. So frequently combination therapy, like in normal ordinary patients, is used in these patients as well. When we look at the drugs, the beta blockers can be used, especially if you're looking at cardiac morbidities or if you're looking at patients who have CNI-induced tremors. Calcium channel blockers are good for people who have again, cardiac issues where because amlodipines do not cause bradycardias, but yes, we have to keep in mind the interaction with the CNIs and the incidence of edema. Diuretics and clonidine have been widely used and they are pretty safe drugs. And when we talk about ACE inhibitors, we have to be very careful when we use with patients with renal insufficiency. And also we have to monitor hyperkalemia because this is another effect that we see with the CNIs. But of course, ACE inhibitors can be used in patients who have concomitant diabetes as well. Now, new onset diabetes after transplant, or NODAT as we call it, this has been defined as fasting plasma glucose of more than 126 milligrams per deciliter, or oral glucose tolerance test with a 2-hour glucose of more than 140 to 199 milligrams per deciliter. So here the incidence has been recorded as 26% in the first year and about 40% in up to 5 years. And various etiologies have been put forth for this, including previous disease, previously existing pancreatic insufficiency, risk factors for diabetes like family history, obesity, again, the use of calcineurin inhibitors, catecholamine response postoperatively, and the use of steroids preoperatively as well as postoperatively. Here, interestingly, when we looked at the difference between using between cyclosporin and tacrolimus, we found a significant increase in the number of diabetes cases when tacrolimus was used. But unfortunately, this is the CNI that is used as maintenance immune suppression for majority of the patients post-lung transplant. So we have to consider and we have to keep screening for diabetes, and if found, then we have to treat it. Now, the treatment approach is similar. The first thing we have to think about is modification possible? Can we switch from tacrolimus to cyclosporin? Is it possible? Or can we use an mTOR, which are certainly known to be less associated with diabetes as compared to tacrolimus? Other than that, start with non-pharmacological therapies of weight loss, diet, exercise, go on to OHAs, a combination of OHAs, and then if required, bring in insulin along with the other oral agents here. Moving on to osteoporosis, this is a very important complication that we see in most of the patients, and it has multiple factors that lead to it, like use of the steroids, use of the CNIs, pre-existing bone disease, vitamin D deficiencies. And then again, as we have been discussing, that many of these patients come to us very late. So they already have an element of cachexia, they already have an element of wasting, both muscle and bone wasting, even before they come in for transplant. And then post-transplant, they do even worse if adequate measures are not taken to correct their calcium and vitamin D balance, the bone calcium deposition, and the same has to be followed in the long term as well. Here, what is recommended is minimum 1,000 milligrams of calcium per day and 800 milligrams of international units of vitamin D per day. In patients who are severely osteoporotic or severely osteopenic or porotic, you can consider high-dose vitamin D as well. Oral or intravenous bisphosphonates, but definitely with bisphosphonate holidays has to be considered. And yearly, or at least once in 2 years, DEXA scan should be repeated for these patients post-transplant to make sure what we are dealing with. Moving on to the malignancies over here, you can clearly see that multiple malignancies are associated with lung transplantation. If you look at the ISHLT data, skin malignancies and lymphomas are the two most common malignancies seen post-transplant, and almost up to 32% of the patients will develop some form of malignancies around 10 years post-survival. Now, not going into details of all the malignancies, I'm just going to focus here on the lung malignancies here. There are 3 types of lung malignancies that we need to look at. One is incident lung cancer at the time of transplantation. That is, we pick up lung cancer in an explanted lung. We look at the development of lung cancer post-transplantation, and then transplantation done for a lung cancer patient. So when we look at incident lung cancer, that means cancer picked up in the explanted lung. Here the prevalence is quite low, variable between 0.5 to 1.5% in different studies. But what is interesting over here is most of these patients had associated COPD or ILD as compared to patients with pulmonary hypertension. And different studies again looked at the outcome for these patients, but unfortunately, the 3-year survival here is again less than 20%. Although the outcome is dependent on what stage the cancer was in the explant lung, but still the 3-year survival was not very good for these patients. Looking at lung cancer development post-transplantation, again, here there is some correlation between the pre-existing disease with COPD and ILD, and the overall prevalence over here is somewhere around 2.5 to 2.8%. Different therapies have been tried over here, which are very similar to lung cancer therapy in a normal patient, with surgery, chemotherapy, and things like fluorodesis being used. Patients are divided in according to the TNM category and then appropriately treated. But again, as we saw in the incident lung cancer area, when patients develop lung cancer post-transplantation, again, outcome is almost less than 20% in over 3 years. Coming to a very interesting aspect of lung cancers, using lung transplant as a treatment modality for bronchoalveolar cell carcinoma or adenocarcinoma lipidic type, as it has been reclassified as. So this is one large study where out of 21,000 from the UNOS registry, out of 21,553 lung transplants, 29 patients underwent bronchoalveolar cell carcinoma of BAC, underwent lung transplantation. And when we look at the survival for these patients, we find a very striking that overall survival, although slightly reduced, is not very different from the survival in overall lung transplant. So if you look at this graph, the dotted line depicts this overall survival post-lung transplantation, and the solid line shows you survival in cases of BAC. So survival is pretty good. That means lung transplantation can be offered as a therapy for patients with bronchoalveolar cell carcinoma. Going back to some of the metabolic conditions, one other major problem that we see is issues with the kidney. So severe renal dysfunction starts developing within 1 year in about 5% of the cases, goes on to 16% in 5 years, and about 25% of the patients will develop CKD in 10 years' time, out of which around 3.5% cases may require a renal transplant, and about 6.4% cases will go on to need dialysis. So Other than that, the other metabolic conditions that we have to carefully associate or carefully check for is hyperammonemia. So this is one of the rare complications that is seen usually immediately post-transplant and is very fatal unless identified early and requires intensive therapy for that. Diaphragmatic dysfunctions due to phrenic nerve injury is a common surgical complication that can be seen. Skeletal muscle weakness due to deconditioning, steroid-induced myopathy, or critical illness myopathies are often seen. Dyslipidemia, again associated with the use of calcineurin inhibitors, is seen in about 59-60% of the patients. CNIs can also lead to different manifestations of neurological toxicities, such as seizures, brain edemas, tremors, and other things. And other malignancies like lymphomas, Kaposi sarcomas can also seen to be developed. So overall, what we've covered is basically different types of metabolic and airway complications that we see post-transplant. So one comment that I would like over here is make over here is, how do we follow these patients up once they go out of the transplant unit, once they go back to the city that they came from, and once they go back to the referring physician? So we have developed a protocol where we do biopsies at regular intervals, like at 1 month, 3 months, 6 months, and then 1 year in the first year, and then one biopsy every year after that till the patient is doing fine. So these are set protocol biopsies wherein multiple investigations will be done prior to biopsies to rule out all cases of infection or rejection in these patients, and have to be carried out at the transplant center. But other than that, we kind of have developed a mechanism wherein we remain in touch with our patients by way of a WhatsApp group, wherein they would send us daily FEV1 values from a small vitellograph that we hand over to them before they leave the unit. These values are plotted by our coordinators into a chart, and any significant dip or any more than 10% dip that we see, which is maintaining over these in the values, raises a red flag. And then we call the patient, ask him to go back to first the treating physician to identify what is going wrong. And then if required, they come back to the transplant team. The physicians are also given a chart wherein we can tell them how often they need to look for these metabolic causes, how often they need to order blood investigation and imaging investigations to look for these metabolic areas and to rule out other malignancies. And then a close relationship has to be developed between the referring physician and between the transplant team. And that is how we can ensure that not only lung transplantation gives them an immediate post-transplant survival, but this survival can be maintained for a very long period of time. And that is ultimately what will be more fruitful. So I'll end my talk with that, and maybe we can take up more questions during the panel.
Thanks, Apar. Absolutely brilliant. Very, very relevant issues for all of us. I think we've had a very, very good set of lectures. We've got a bit more than half an hour in which we can ask some questions. So can all of you turn your videos on so that I can actually see all of you? So Deborah, Vaidehi, Harish, can we just, can you turn your videos on, please? Grand. So we'll start off with Dr. Suresh Rao, because we haven't managed to get him into the discussion till now, but just a couple of housekeeping rules. If you can keep the answers short and concise. If you have something to add to a question that's been answered by someone else, if you see the reactions at the bottom, you see a hand. So if you can just put the hand up like I have just now, I know that you want to speak. So that would be great. Or you could just put your hand up. That would be perfect. Yeah, so grand. So if you did that, keep your answer short and concise, put your hand up. We shouldn't be talking across each other. And we'll start off with Dr. Suresh Rao. Dr. Suresh Rao, Dr. Balakrishnan touched on this before. Could you please briefly outline the donor management and assessment issues, which we've not really touched on in any detail during the meeting? So about donors, management and assessment issues, please.
Yeah, I think it's a very important topic. As Dr. Bala pointed out, if you can use 70% of the hearts, it's only 30% of the lungs we can procure because of the improper donor management. Now, coming to the specific points, there are some general management rules which applies to all the organs, like management of hypotension or shock, because it may be because of the hypovolemia, or it may be vasodilatory shock, or it may be cardiogenic shock. and the treatment varies depending upon the cause. They also will have hormonal imbalances. It may be vasopressin deficiency or diabetic insipidus or thyroxine deficiency. So you may have to start thyroxine or T3, or they may be having adrenaline insufficiency. So usually we give methylprednisolone 15 milligram per kg, and also proper glucose management. Usually they will have hyperglycemia. Now coming to the specific management for lungs, first thing is you do a bronchoscopy and clear the secretions that will optimize the oxygenation. Then ventilatory management is very crucial. We need to have a protective ventilation. Usually keep tidal volume of less than or equal to 6 ml per kg. With, if the oxygen saturations are low, we try to go up on the PEEP. And the driving pressure is always kept below 15 millimeter of mercury, so that the plateau pressure does not exceed 25 millimeter of mercury, so the lungs are protected well. In some patients, they try very low tidal volume, like 3 ml per kg. However, it may cause hypercapnia, other organs may not, it may cause harm to the other organs. So its role is doubtful. And the next thing is proper fluid management. We usually go for restrictive fluid policy. When there is a hypotension, you may give some fluids. We prefer usually colloids or crystalloids, but once you achieve the hemodynamics, we try to give diuretics so that you have zero balance or negative fluid balance. And there are other drugs like high dose albuterol, N-acetylcysteine, nitric oxide, so many other drugs are tried out. Of course, they are all controversial. And coming to the assessment of the donor, again, most of the time when we get an alert, we go through the most of the information we get through phone regarding the age of the patient, smoking history, the ABG reports, even X-ray, CT, all these we can get it through WhatsApp. We also look for the comorbidities, the blood group, serology, the cause of death, any comorbidities, smoking history, trauma to the chest, and any secretion, ET secretions, so, and sometimes fiber optic bronchoscopy findings also. However, once you reach to the hospital, again we do a bronchoscopy and look for any secretions, repeat the arterial blood gases. If there are so much secretions, we'll clear everything, repeat the ABG. And finally, the surgeons will open the chest, directly examine the lung, because there may be contusions, there may be collapse of the lung, or sometimes pleural adhesions, or sometimes bullae, sometimes nodules. So all these things needs to be done once the chest is open.
Sure. So, Dr. Suresh, sorry, I'm just interrupting you for a minute. So you talked about history, you talked about seeing the individual who's going to donate the organ, about opening the chest up. Give us an idea as to what would make you decide, okay, this man would actually, or woman would actually function fine as a donor, whereas another person, this is probably a no-no as a donor. What would make you decide either way?
Yeah. So if you look at the ideal lung donor, ideally age should be less than 55 years. Of course, we have also taken 55 to 70 years. Again, it is suboptimal, but it can be used. Above 70, again, it is controversial. A couple of times we used successfully without any primary graft dysfunction. But the ideal age is less than 55 years. Then coming to the smoking history, less than 20 packs per year is ideal. 20 to 40, it is suboptimal. Above 40 is again controversial. And they should not have any other diseases like hepatitis B or malignancy, diabetes. However, in suboptimal cases, hepatitis B can be treated. Even hepatitis C can be treated. So we have taken organs. And some malignancies, there is low risk of transmission. Again, you can take. Diabetes, again, it can cause some amount of vascular disease in the donor lung, but we have accepted. And they should not have any pulmonary infection, ideally. But a couple of times we have gone, first bronchoscopy, we had some secretions which looks like infectious, we clear it. After that, if there is no reaccumulation of secretions, we have accepted the lung. And important thing is the ABG PF ratio. Anything above 300, it is ideal. But 200 to 300, again, it is suboptimal, but we have accepted. Below 100, so far we have not accepted, but I'm sure with the ex vivo perfusion, all those technology, if the low PF ratio is because of the pulmonary edema, still it can be used. If it is because of infection, probably it's not an ideal lung. And of course, there should be appropriate blood group matching the donor, and also the size. Usually we predicted total lung capacity. The ratio between the recipient and the donor should be anywhere between 0.9 to 1.3. Of course, we have accepted larger lung also. Sometimes we did the wedge resection and transplanted. So these are all the ideal lung. That's what we look at.
Right. Thank you. Thank you, Dr. Suresh. That's very, very useful. Quick question. I'll start off with Harish and then I'll ask the same question to Dr. Balakrishnan. So Harish, I wanted to ask you, you've got a patient who is stable, end-stage lung disease, but is relatively stable. And then you've got the patient that both you and Dr. Balakrishnan spoke about, invasive mechanical ventilation on ECMO, acutely unwell. Often in our cohort of patients, the families come in and say, can this guy on a mechanical ventilator, maybe on ECMO, can he get transplanted? So I wanted your views on what sort of results you would expect. How mature should the center be before they start taking patients on an invasive mechanical ventilator on ECMO versus the stable patients? Your thought about these two categories of patient is what I wondered about. So Harish first and then Bala.
That's a great question. So I think the age of the recipient and the duration of illness are the two things that drive this process. And as Dr. Bala showed in his videos, a younger person walking on ECMO, he would probably do really well. And the need is justified for an immediate organ transplantation in that person. The next thing is, in a stable person, it is about philosophy of a precious resource of donor lungs and proximity of the patient to a transplant center. And those are the two things that we in our country, we try to restrict organs within 150 to 250 mile radius from the donor center. And whoever has the highest need driven by lung allocation score, they get allocated the lungs.
Right. Okay. Dr. Balakrishnan?
Yes, you have to understand a few things. One is, unlike the United States or Western Europe, transplant programs in this country are not funded by any agency. So it's essentially a relationship between the patient, his family, and the treating hospital or the doctors. So the second issue is the fact that a donor organ is not, there are more organs available at this point in time that are being utilized, except in our city or in our state. Most other states, more donor lungs are available than that are being utilized. So given that caveat, we really look at, you're going to put a patient on ECMO only if there's a reasonable chance that he or she has a possibility of surviving transplant. If that's ruled out, in my opinion, there's no point in putting a patient in ECMO if beyond ECMO there's no solution. So the cutoff happens even before you put a patient in ECMO. And once you do that, I guess we try our best to get an organ as quickly as possible. A large percentage of the patients that at least I treat, because of the fact that for a long time I've been doing a whole lot of congenital heart disease. A lot of my referral-based patients with pulmonary hypertension. So they come, a lot of them are younger patients. They're very sick with depressed right ventricular function. So by and large, despite the fact that they are sick and they often go on ECMO, they actually do surprisingly well. So we have a fairly liberal approach to patients on ECMO, depending on the category of patients who come to us for transplant.
And Dr. Balakrishnan, what sort of mortality, when you we heard the 6.5 years, 50% mortality a little while ago. So how would you compare the mortality in the acute scenario, in the so-called acute scenario, versus the chronic stable scenario? What sort of mortality?
The risk of patients being on ECMO and being transplanted gets neutralized once they survive, and beyond 6 months, the survival is no different from those patients who had an elective transplant. I mean, that video I showed of the guy who was in ECMO for 60 days, he's alive now at 4.5 years down the line. It's absolutely normal. So the risk of death gets neutralized in the first 3 months. So if they're beyond that, it's no different from a more stable elective lung transplant.
So what about the first 3 months, Bala and then Harish, quickly? What about the
mortality? The mortality is higher for patients on ECMO as compared to those who come walking. And it also depends on whether the ECMO is for acute deterioration of lung function or an otherwise well-preserved patient as compared to a chronically fragile, sick individual who's not walked for a long time with acute deterioration on the background of a chronic lung disease, in which case they tend to do more poorly.
Right.
Yeah. Two things. In our experience, post-ECMO transplants, they always have infections and prolonged vent dependence because of myopathy and weakness. And infections, we don't know why, but ECMO tries to probably dilute the complement innate immunity factors, and they probably are more prone to develop infections. Once, I want to add, Dr. Bala, this is our time in India. I want to point out a little story. The International Society of Heart and Lung Transplantation was formed in the garage in a Texas suburb of few cardiothoracic surgeons inviting few Europeans, and that's how the society formed. So I just want to state that surgeons like you and pulmonologists like in the audience should take it upon yourself to create a standard and establish it in, this is the time to do that. And before every center claims that they do transplants, one should establish a standard of care. And people like you should take up that responsibility and deal with the government at the national level and change a policy.
Sure, Harish, fair point. I can promise you, even on Bala's behalf, that is something that he does a lot of. And I can sort of vouch for that. Advocacy is something that Bala does a lot of. So I'll come to Vaidehi and then to Apar. Similar set of questions again, but more from a pulmonologist perspective. So you touched, Vaidehi, on the fact that people who have to sell their assets or actually procure money, it's actually going to be a challenge for them to undergo transplantation. But people like Apar, Bala, and Dr. Rao would actually swear to the fact that there's a lot of these people in India. And you probably cannot come away from the fact that there's always a balance between what the expectations of the patients are who's spending a lot of money in undergoing a transplant and what the buyback is in the number of years of life that people have. So I think that's something that is in everyone's mind, at least the ones I have actually sent across to for transplant. So what I wanted to ask you was, when we speak to our patients and they are going for a potentially expensive undertaking, if these people are actually the right candidates for transplant, in your view, how do we go about counseling them? What do we tell them, tell the family? How do we answer their expectations about the lifespan post-transplantation, etc.? How would you go about counseling? And then I'll ask the same question to Apar.
Thank you. So I think there are three things that if I were a referring physician in the community, there are three things that I would want to counsel a patient about. One is certainly looking at financial aspects, and because And the second most important thing is, I don't think we should really, as a community pulmonologist, if I were seeing a patient trying to help them out for a transplant consideration, I don't think we should refer them to a center, like Harish pointed out, who is probably just going to be starting off, and the goal is not about numbers. The goal of a transplant program should be about, are we going to make things better for the patient long term, not short term? Are we going to be making a difference for 6 months, for a year, or is this going to be a long term outcome? So that's one thing from when you're thinking of referring to a transplant program, as far as a program itself that's doing transplants. Second thing, as a pulmonologist, I think you may also want to think about what is the spectrum of disease that they are looking at. A young patient, like Dr. Bala pointed out, severe pulmonary hypertension, who otherwise does not have a lot of other issues, could be a straightforward transplant case, compared to somebody who has post-tuberculous bronchiectasis with a lot of infections and a lot of pleural disease. And you would, as a community pulmonologist, I would say that patient would need constant ID surveillance. That patient would have a lot of airway complications. That patient would have a longer hospital stay after transplantation. So having some knowledge about what transplant brings to the table as a community pulmonologist would be very helpful in counseling the patient whether the outcome would predicted outcome would be good, or whether we would run into a lot of problems. And I think uh, just keeping in mind, whether are you supporting the patient to live longer with a better quality of life, versus the other financial aspect, where the rest of the family would probably be driven into a compromised scenario, is something that I think a community pulmonologist would probably be able to tease it out based on the relationship you have with the patient. In general, when somebody comes for a transplant referral, we also have lengthy conversations, especially from the financial and social aspect, because those are the two pillars for a successful outcome.
Thanks, Vaidehi. Apar.
So you put me on the spot, because it's very difficult to take a question that Vede is already answered. There's hardly anything to add on to that, but I'll bring in some of the Indian aspects over here. So two things when we are counseling a patient that we look at is, we tell them that this is not just for the survival benefit, but as Vede again has already commented upon, we talk to them about the quality of life post-transplant. Now, having said that, that is the benefit that the transplant is going to offer to them. But what we need to realize very carefully is the social aspect, the financial aspect, and also the psychological aspect of it. A complete deep understanding of the entire family structure has to be obtained at the transplant center, or even at the level of the referring physician, that whether this patient can afford it. And it's not just about the transplant, whether the patient can afford the cost of the immune suppressants that he has to use, the cost of the biopsies that have to be taken in, and also keeping into mind that some complications do develop, whether he would be able to afford and whether he would be compliant with all the therapy that will help him lead a healthy and useful life post-transplantation. Now, keeping this into mind.
Yeah. So Apar, I take your point. Sorry, I'm interrupting. I take your point. So I think, like you said, Vaidehi, he touched on these things. But from an Indian perspective, you have patients and I have patients who would go to any extent, sell off anything for a 20-year-old with a familial ILD, for instance, or someone with cystic fibrosis who's young, to get a transplant done. And I guess there's always this mismatch, because most people are paying out of their pockets. There's a mismatch between the expectations these people have and what they're actually going to achieve. And they correlate it with their finances, with the money. So this question of how much can they pay, what can they pay, is going to be very relative as to how important the family feels the transplant is for the individual. So from that perspective, I think counseling in our country is very different to what it is in the West, from the structure which Vaidehi spoke about. So have you faced these challenges? Maybe if you give us an example, patient sent by me, for instance, going to you for a transplant, you've seen that there's a mismatch between expectations, and what you tell that patient is what I was actually asking.
So absolutely. So there are two things over here, and I'll give you two scenarios. So one, let's talk about one of the patients that actually you had also sent to me. So this is again a poor family, but they when we talked to them, when we looked at the resources that they have, there was an ability to maintain a healthy lifestyle post-transplant. So the good thing about that is, as Dr. Bala also mentioned, that in certain states of the country, the government funds the transplant for some patients up to a certain extent. The other good thing is that there are multiple NGOs and there are online agencies which help crowdfund and collect funds, raise funds for the surgical aspect, for the transplant for these patients. And many of these patients have benefited from that. So they come up with a certain amount, and since all of them are paying out of their pocket, and the rest is met by using these agencies. So a very important point over here is then we have to look at the utility of the transplant. A very elderly gentleman who's already quite sick may neither have the time for these agencies to help him collect the funds, nor it would be more useful. So keeping into mind all those aspects, we have to talk to the family.
Right. Grand. Thank you. So I can see in the chat box, there's Harish and there's Deborah saying that these are universal challenges. These are challenges which are faced across continents, and it's not peculiar to India. So thank you, guys. I'll come to Deborah next. So Deborah, I'll ask a couple of questions first, which have come in from the audience, and then go for a question that's from your talk. So a repetition that's coming from the audience is, what sort of age would be a cutoff when you think about sending your patient across for transplant? And the other question is about the size of the individual. So a kid versus someone who is very large built. So when you're trying to sort of transplant these, what would your mindset be? What are your cutoffs in your book?
In terms of age, in terms of the criteria for what age people should be a cutoff on are very, it's varied throughout the country and even inter-center. So center-specific people throughout the country, however, usually have a cutoff of around 70. Some patients, some centers go up to maybe 75 and some may go down to 65. I know in some of the European countries and some of the European centers, it's even lower. So I think it's center specific, and it's really based on the experience and the ability to understand that population for that particular center. Again, there's always people that will come in over that age, and they may be very, very healthy and they may have no comorbidities. And you may say, hey, I'll go a little bit above my age. And I think that's true for most centers. They take the person as an individual and they say, hey, you're the community physician. Sometimes what I like is when the community physician reaches out to me, we discuss the patient, especially if the patient has to travel far, and we talk about the patient. Hey, this patient's 75, but I really feel you should take a look at him because I feel he looks solid in terms of being able to get through this. And that, that conversation can really help either, defer the idea that the patient even needs to travel all that way because they're not a candidate, or make it easier for the center to say, I'm going to take a look. And I think most centers will say, you know what, let me just take a look. We'll look at everything and we'll be able to say whether the patient's a candidate or not. When you're talking about size, I think there's size in terms of weight and size in terms of height. Let's talk about size or BMI first. So body mass index is also one of the criteria that the International Society of Heart Lung looked at to decide, hey, what could be dangerous and what could be safe. And I think in terms of contraindication to transplant, most centers say at least a guideline, and again, there's people above and below, say, a high BMI of greater than between 30 and 35 is really what they look for at time of transplant. However, if a patient comes to us with a BMI of 40, guess what? It is a changeable risk factor. That's something that's not age. I can change a person's risk factors. We've had patients lose 100 pounds, excuse me, just to get the transplant. So absolutely refer your patients who are too high in their BMI because that can be reversible. The opposite also occurs, patients who are too low in their BMI. We had a patient who came who absolutely was not being able to get a transplant. Their BMI was 14. However, with different modalities and a feeding tube, that patient was able to get to kind of the BMI of 18, 19. Again, too high and too low are something important. When you look at height, I know this is the last thing you talked about, size.
Sure.
This is very difficult because that's something that's not changeable. However, that doesn't mean the patient can't be a candidate. It just makes it possibly more difficult to get a donor. So those patients may be on the list longer periods of time. When you look at very small women with very small lungs, it becomes sometimes hard depending on where region you are and where you are. On the other side, if you get a patient who's 6'5", 6 feet 5 inches, or very, very tall, and maybe has COPD with very large lungs, that also may be difficult. And so these are things that you look at, and when you talk about the size, you have to look at what your center would
Sure. Thanks, Deborah. So Suresh, quick word from an Indian perspective. Any different from age and size? Do you think it's anything different to what Deborah has mentioned, or would you sort of operate on people who are above 70, for instance? Would you have done that? Or maybe Bala with a quick comment?
Yeah, I think size mismatch is a major, this one in Indian context also. But most of the time when we have more number of recipients, we'll try to match the TLC. In fact, we try to do a 3D reconstruction of the CT of the recipient and try to evaluate the size of the lung and how they fit into the recipient. So apart from that, anything from Bala? Dr. Bala want to comment?
Two things. One is in this country, it's not common to have very fat people like you have in the US. And we don't often have 6 feet 8 inches tall basketball players. I mean, so that's not something I have great experience on, dealing with very tall people. But we often have the problem of young patients or young or small build patients, and the donor lung on offer is big. That's much more common, especially in my practice where I said a lot of my patients are pulmonary hypertension in 12, 14, 16, 24-year-old women, for instance. And the donors are often bigger. So and the thing about donor lungs is if the size is an ideal fit, the lungs might be infected. So everything doesn't fit together all the time. So you have to compromise on one or the other. So we are fairly liberal in chopping off bits of lung to fit it into the chest cavity. I mean, we have a very low threshold for linear resections, and the outcomes have been pretty good. It has not affected outcomes in a big way. Sometimes if it's an especially a smaller pediatric patient, we have done lobar transplant. The other question of old age, the oldest we have done is a 70. I think we have done 3 patients over the age of 70, where we have put in a single lung. Age is a number. So eventually you look at, even in the cardiac domain, we look at the biological age in terms of frailty and other things. So if they're otherwise well preserved, they tend to do quite well. So we've done, I think, 3 patients over the age of 70, and all 3 are alive.
Grand. Thanks, Bala. So I've got, I have had Harish, who's actually posted quite a lot of info. So on this, he said, contrary to traditional teaching. So contrary to traditional teaching, selecting larger lungs with a height ratio of greater than 1 may benefit recipients with IPF and COPD. So that's one carry-home message from Harish. Harish, I'll ask you the next question. We spoke a little bit about pre-transplant rehab, but would you expand a little bit about how important it is and how you go about doing it briefly? I mean, sort of touch on it so that the audience knows about pre-transplant rehab.
Rehab is an important part until the day of transplant. Pulmonary rehab availability for lung transplant centers is a challenge, at least in my program. So what I have decided is people who can walk, they should walk with a minimum amount of oxygen and turn it up to the maximum, and walk as much as possible. If they're not able to walk, put a 1-foot stool and climb up on it and down as much as you can and repeat it as much as you can. And also the proximal muscle strength of the upper extremities, which is lifting 5 pounds or 2-pound weights and trying to exercise above shoulder and below shoulder. These are simple exercises. Why it is important is 3 things. When they are moving and exerting themselves, their diaphragms are splinting and they are exercising their diaphragms, especially in restrictive lung diseases. And also in obstructive lung diseases when the diaphragms are flattened and they may not kick in immediately after transplant. 1. Their ability to get out of bed to chair and participate with PT, which is the proximal muscle strength, which is affected by the early course of steroids. By practicing stepping on the stool repeatedly, that's the group of muscles that really work. And we want them to at least be able to transfer themselves out of bed and stand. If they're able to do that, then for the next part, the core muscles are intact, then they can participate in inpatient rehab in the hospital and get better. And the upper extremity strength is primarily to facilitate their respiratory drive, especially after a clamshell incision. They may not have enough inspiratory effort. So when the sternocleidomastoids and traps are exercised, they're able to breathe and come off the vent easily.
Right. Grand. Thanks, Harish. So quick question. We've got about 5 or 7 minutes left. So sort of brief questions, brief answers, please. So I'll start off with asking Deborah. Deborah, you spoke very eloquently about acute and chronic rejection. So for a patient going back to the primary physician, the referring physician, how would they actually think about acute and chronic rejection in that scenario once the patient, so not maybe about acute, but about chronic rejection when the patient has gone back to their home center?
So in terms of chronic, right?
Yeah.
Looking at chronic rejection. Again, I think knowing when a patient's in chronic rejection may not be easily identified because the PFTs may still be very good and patients feel very well, but they're definitely, their PFTs have gone down. If a person started with an FEV1 of 3.6 liters and they went down to 2.6 liters, that they still feel very good. They still have a great lung function. However, they've dropped a liter of their function. So following PFTs is very important, even when the patient goes back to their home physician. I think that is something that we need to continue to follow, even if they're not at the center. If the PFTs are down, and they're persistently down as the CLAD definition signifies, then the center should be notified because there are therapies, not all great, that can be tried that may not be available in the home city, but may be at the center. So I think very good communication between center and
Sure.
primary pulmonologist.
Sure. Thanks, Deborah. So I'll sort of hold you onto that thought and go to Vaidehi and Apar, 2 different continents. So with COVID, so Deborah just spoke about spirometries. Apar mentioned about how important bronchoscopies are. We know this is going to be a challenge for at least the next 1 year going forward, both in the US and in India. How do you think the transplant program needs to sort of readjust itself, given the fact that we are in the middle of a pandemic, which is going to go on for a while, in monitoring these patients based on spirometries and bronchoscopies?
Well, very good question, and something I think we're all dealing with, but I think many patients or many centers are going towards more of a telehealth type situation. So using these types of modalities, like these platforms, like webinars for our visits, all of our patients were supplied with or bought home spirometers. Some of these home spirometers can just be uploaded into their phone and emailed to us, or if they're not that technical savvy, they will get they'll just write them down and email us the sheet. Following PFTs at home is very important. coming to more maybe closer laboratories if they need labs like prograph levels and things like that is also important. So keeping the patient safe is number one. And as each center feels comfortable, maybe coming in. In terms of testing people and spirometry in the center and COVID, I think each center is so drastically different.
Sure.
Some centers want you to have a COVID test before doing spirometry or full PFTs, and some look more at just other types of
Sure.
evaluation.
Sure. So Vaidehi, bronchoscopies. What do you think about bronchoscopies post-transplant for follow-up in the COVID era?
That's a very important question. And I think as we understand a little bit more, whatever I say today is going to be different a month from now, because there's change in technology, there's change in testing. And at the moment, we are not doing surveillance bronchoscopies. We are only doing bronchoscopies for an issue that comes up. And most of all our patients are having the COVID testing done before bronchoscopies. But I think the platforms with like the Cepheid platform that came out, or the point of care testing platform that came out, or the antibody testing that came out, I think the expense may be better I think expense and cost is the most important issue at this time. I believe that's the case in India as well. And the limitations for access to testing, because it's whether it's government controlled or federally controlled or state controlled, is other limitation. But as things evolve, I think things will probably be much better. But I can tell you that patients on immunosuppression, at least I have not seen the same amount of surge of cytokine storms and acute illness. At least we've seen one case that I've discussed with Harish earlier when we had problems, but in other solid organ recipients in our program, we have not seen the same kind of surge that we're seeing in somebody who is 45 coming with COVID and having like
Sure.
ARDS pattern.
Sure. Sure. Thanks, Vaidehi. So Apar, I know you're planning to restart the program again, or you've restarted. How do you plan to do your post-transplant follow-ups in these patients?
So yes, so to answer that, the program has restarted. So the government of Tamil Nadu has taken a strategic decisions along with NOTO, the national agency, and they've come up with proper guidelines how the donor can be screened, how the recipients need to be screened, and what precautions need to be taken while keeping the transplant team separate in the hospital, the area separate in the hospital from separate from where the COVID patients are being managed. So all that infrastructure has been advised, and the hospitals have complied with that. So giving a reboost to the transplant programs all over. Now, the important point over here, as you said, comes to the surveillance. While these patients are in the hospital, it's a different issue. It's in a controlled environment and things can be managed. But once they go back home, there is a lot of exposure and we never know what they get with. So as Deborah and Vede have already pointed out, I think the important point is to look at the symptomatology and look at things like home spirometers. So from the beginning, as a routine, we've been giving vitalographs to all our patients, and they kind of do an FEV1 value daily, morning and evening, and send it to us, which our coordinators keep plotting on a daily basis. So this helps us very sensitively to look at any fall in the FEV1s or any decline in the lung functions before it hits a severe point. In case we see things like that, or patients come back with symptoms of breathlessness, decreased exercise capacities, or for desaturations, then of course, these are patients who would definitely need bronchoscopy. So COVID testing and then look at them. I think bronchoscopy is the investigation of choice.
Right. So Harish, I'm sorry, I wasn't aware that you have the largest experience. I'm being pointed out by all the other faculty members that you are the most experienced. So I'll add a question. What are your worries about immunosuppression post-transplant in these patients in the COVID era? And anything that you wanted to add about follow-up of these patients in the long term, quickly. Thanks.
Decreasing the cell cycle inhibitors and minimizing steroids is very important. And we have tried to reduce the calcineurin too. And unfortunately for kidney transplants, they did not fare well when compared to every other solid organ transplant. So.
Right. Okay. And anything you wanted to mention about the follow-up of these patients? I mean, aside from the immunosuppression bit, anything that you wanted to add to what Deborah or Vaidehi or Apar said?
They take a long time to clear up the virus because they have been immune suppressed for a long time. So they have remained infectious for a long time.
Sure.
And the study where it's the Nature Medicine is probably coming up, that the immune homeostasis is really distorted in COVID-19 in transplant patients. And there are a lot of cytokine profiles, and but the viral load does go down eventually, and they do turn negative.
Sure. Sure. I mean, I completely agree with my experience of COVID. I think not maybe in the post-transplant population, but any patient on oral steroids because they have maybe ILD or maybe on a mycophenolate, for instance, the virus just takes ages to clear out. So I completely agree with that, with you on that point. So completely different tack. Last couple of questions. Bala, I come to you. So tell us a little bit about how you decide between a lung and a lung plus a heart, and what you think is the sort of the risk benefits as far as mortality is concerned with sort of lung versus lung heart.
Okay, our heart-lung transplant is almost exclusively reserved for patients with Eisenmenger. So when they have a heart disease, unfortunately in this country, we continue to see large number of patients who have been neglected. VSD, Eisenmenger is a crime. We still see that in a 20-year-old patient because we've been closing infant VSDs in this city from the year 1985, but such is life. So we tried closing the VSD and then lung transplant. It's not, the outcomes are not as predictable, and that's been actually shown by the group from Toronto Children's as well. So for Eisenmenger, unless it's an atrial septal defect of some kind where, so majority of patients, I did a truncus arteriosus heart-lung transplant 8 months ago. I mean, imagine a 47-year-old truncus arteriosus with truncal regurg, severe biventricular dysfunction. So that is one category. In the beginning, when we had severe RV dysfunction with primary pulmonary hypertension, the temptation was to do a heart and lung transplant because we didn't want to deal with, in the early part of the lung transplant experience, deal with depressed right ventricular function. But the waiting times for a heart-lung are much longer than either for a heart alone or a lung alone. And size becomes a bigger issue. So increasingly, 95 times out of 100, we would do a bilateral lung, even if the RV function is severely depressed. A significant number of patients with bilateral lung transplant for pulmonary hypertension, especially with RV dysfunction, they have a chronically underfilled left ventricle. They might require some VA ECMO support. We have a fairly low threshold for continuing the ECMO postoperatively for the left ventricle to get used to the preload that is imposed after the lung is transplanted. Our own experience has been patients with either a naturally occurring atrial septal defect or in those where an atrial septal fenestration has been created either by a stent or by some kind of a septostomy to decompress the right side, tend to actually do better after a primary bilateral lung transplant, not require ECMO as much as those with an intact atrial septal. That's our policy at this point in time.
Right, grand. So structural lung disease, so Bala, so things like bad COPD, disproportionate pulmonary hypertension, maybe an NSIP, which might be due to scleroderma, for instance, not responsive to standard medications, severe pulmonary hypertension, wouldn't get considered for a heart-lung?
No, I don't think so.
Okay.
To a large extent, we try to manage just with lungs.
Okay. So I'll maybe come to the last question. I think we've more or less sort of exhausted our time once over. So maybe I'll ask Harish and then Apar. So infections, Harish. So if you can tell me, I was more interested about maybe fungal infections, NTM, TB, You from New York, so some of these would probably be challenges for you as well as for Apar in the post-transplant period. Your thoughts about these categories? So mycobacteria and fungal is what I was wondering about.
Fungal infections in the voriconazole era has dramatically changed. I've been doing transplants for 15 years now, and I had aspergillus related deaths early in my career, but I do not see that anymore in the voriconazole area, in the era of voriconazole. But newer fungal infections like Pseudosporium, Apiospermium, and Mucor, these are the infections that are very challenging. And we end up doing surgical resections when we have these problems. Atypical mycobacteria, other than M. abscessus, is usually not a problem, but M. abscessus, Mycobacterium abscessus, needs surgical intervention when feasible. And this is my take on the infection part.
Right. Thanks, Hari. Apar, last 1 minute, anything about Indian experience with infections, especially the fungal and TB?
So I don't think we are that unlike in that aspect. We've also not seen too many fungal infections here. Of course, we've seen some perianasmotic aspergillus growing in there, but deaths because of fungal infection or invasive aspergillosis developing in these immunocompromised patients post-lung transplant with voriconazole prophylaxis is very, very rare. I mean, we haven't seen in our program as yet.
Sure.
And
Sure.
Surprisingly, one thing that surprises all of us is being in a heavy TB burden country, we would expect that post-lung transplant with the immune suppression, we would see loads and loads of TB, but we've not seen that much.
Sure.
Happen, or give it time, it will happen, trust me.
So, Bala, you wanted to say something. Did I see a hand?
Yeah, I did. Not in the context of lung transplant alone. We have a very large experience of heart transplants. We've done over 370 cases. What actually, when we started off, as Apar said, in a country with so much of issues of tuberculosis, waterborne diseases, we expected much more infectious complications, and surprisingly, it is not overwhelmed us as everyone would have imagined. I mean, that's, I'm not saying infections don't happen, but it's clearly not as rampant as you would have imagined, given the magnitude of infectious diseases in the community at large.
Sure. Right. Grant, thank you. So I think we have badly run out of time. Before I thank everyone, Apar, parting comments from your side.
I think this was a wonderful discussion. I thank everybody, from my side for being part of this event so that we can create more awareness. We can spread out words about the different aspects of transplant pulmonology amongst the physicians and amongst the pulmonologists who are practicing out in the community. And beautifully, I think we've touched upon all different aspects, starting from end-stage lung disease management from the perspective of transplant to identification of the ideal candidate, following up of these patients, looking at rejections, and also what are the challenges from the program level to all the way up to the government, national policymaker levels. And then beautifully, Dr. Rao has also brought in the donor aspects of it. And then finally, I thank Raja for conducting this meeting so beautifully and so cohesively that you've done. And of course, I can't not thank two other organizations. One is the Indian Chess Society, Dr. Christopher, Dr. Rajesh Varnakar, for making the event happen, and Lupin, our main sponsors for the event. So with that,
thanks, Apar. You've done all the hard work for me. So thank you from the Indian Chess Society, from all of us in the Indian Chess Society. It was an honor to host all of you. So Bala, Suresh, Deborah, Vedehi, Harish, thank you to all of you. Apar is from home, so I won't thank him separately. It's been an honor and a privilege hosting this program. I hope the audience got something out of it. Do get back to the Indian Chess Society with your comments and your feedback, people who've been listening in. I'm told there's more than 600 people who've actually logged in and are still there. So thank you everyone for listening in, and a good night from India. I know you guys are in the US are starting your day, but good night from all of us. Bye-bye. Take care.
bye.
Thank you all. Thank you.
Thank you so much. I'm ending the meeting now. So thank you.
Thank you. Thanks, Manu. Thanks, Deb.
Thanks, Apar. I loved it.
Thank you so much for being a part of it.
Oh, it was great. You did a great job. Congrats.
Thank you.
Thanks, Dr. Apar.
Thanks.